You sent a text?
One second, chat. Yes, good morning. I'm having audio issues. Not able to hear. Please feel free to start. Okay, so everybody's ready?
Good morning.
Thanks again for having us in the very respected forum. I have Dr. Slav Gaft. He's one of our surgical residents. He was involved in this case. We have a lot of things that we learned from this case, and we wonder if you have anything to add for us. So we'll start with the case. We have a few stops to question you what you will do in this situation. So, Dr. Gaft.
Hi, hello everyone. Thank you for the opportunity to participate in your forum. So today we'll discuss an interesting case of penetrating neck injury in which we had several decision-making points, like in every trauma, which we'll today try to discuss. And as Dr. Schwartz said, to stop at any point and hear your view. Wait a second, a little bit. Oh, am I about to? Okay. So we're talking about a 20 years old male that the onset of the event occurred at 10:47 p.m. You can see the timeline over here that it happened about 10:47. 20 minutes later, EMT arrived, started evacuation 10 minutes later, and then he arrived 7 minutes later to the hospital. The mechanism was penetrating a neck injury, stabbing wound. The injury that we saw was uncontrolled, that they saw uncontrolled bleeding from the left neck. In this point, I would say that they applied direct pressure, and despite this direct pressure, the bleeding was not controlled. He was hemodynamically unstable. What they told us that he had pulses of about 137. Radial pulses were palpable but weak, and the patient was pale. What they did was evaluated him, applied, like I said, the direct pressure and started fluid resuscitation, and then he arrived to the trauma unit. So at the trauma unit, of course, we started the ATLS scan, and we started with the airway. The patient was conscious and talking. We saw a neck swelling at this point, and as I mentioned before, there was an active bleeding despite the direct pressure that we applied. And we understand that we're facing a patient with a pending airway, and at this point we start preparing for intubation. We need to say that.
One second. It's Dr. Ginsburg. I'll be moderating. Can someone mute? There's someone who's not muted.
I think just Lily is the host, so she's the only one that can mute.
Oh boy, she's having trouble with her computer.
Yeah,
so
whoever is not muted, just please mute.
Okay, go on.
Lily, this is Dr. Barron. You can make me the co-host and I can mute people.
Go ahead.
Okay. So as I mentioned, we understood that we're facing a pending airway, like we have to think in any penetrating neck injury, and the team started preparing for difficult intubation. We move on to the B. The patient was apneic with spontaneous breathing. Breath sounds were equal bilaterally, and we didn't see any external signs or subcutaneous emphysema, suggesting for other injuries. The patient had, like we said before, tachycardic. You can see that his blood pressure showing narrow pulse pressure, right, suggesting his hemodynamic state. His Glasgow coma scale was 15, and we didn't see any neurological deficits. And after exposing him, we did not find any other injuries. So at this point, I want you to think, and we'll maybe it's the first question. We're talking about a patient with a pending airway, with a possible difficult intubation and uncontrolled arterial bleeding. The first question, of course, how do you manage the airway? Where do you do it? Whether you do it in the trauma unit, do you do it in the OR? So what are your thoughts about it?
This is Dr. Baron. Can you hear me?
Hello,
Yes.
Albert.
Hi.
Yes, nice to see you. I didn't see you for many.
Nice to see you, Alon. So before we answer that question, you have to tell us what zone of the neck this is injury, and you have to tell us if there's subacute emphysema. Those are the two questions we need to answer first.
I will get back to. I'll move on with this. The zone is what we see, zone 2, and there is no emphysema at this point. Later on, we'll see the
Is it in the posterior neck behind the sternocleidomastoid, or this is an anterior slash injury?
Posterior.
Posterior
Behind
to the
it.
sternocleidomastoid.
Yes.
Okay. So as far as airway management at this point, depending on your resources and depending how soon you can get the patient into the OR, obviously there's going to be a delay. You'll have to do it in a resus bay. If there's no delay, like you're in trauma, which is next door, probably moving the patient to the OR to control the bleeding. But there's other ways in which you can control the bleeding, correct? In addition to direct pressure, you can use balloon tamponade. There's other ways that you can try temporarily until you can get into the neck and then secure the airway. If there's no subacute emphysema, if this is a posterior injury and you do not therefore suspect airway injury, the most efficient way to secure the airway is with rapid sequence induction.
Where would you do this?
As I said, depending on your resources, at Ryder probably would just move the patient to the OR, which is next door. But if you're in a place that the OR is far away, you're going to have to secure their airway in the resus bay.
Someone needs to mute.
Hugo Garcia, you need to mute.
Good.
Okay. Any other opinions? Should we
Dr.
do rapid sequence in the trauma bay, in the OR? How we can control this bleeding, uncontrolled bleeding?
This is Dr. Ginsburg. These are my comments, and then we'll go to Dr. Kasim. Afterwards, I'm supposed to moderate. The issue here is that it's a posterior sternocleidomastoid injury, posterior to the sternocleidomastoid, which still doesn't mean that it can't hit the carotids or anterior structures. But my concern with this patient is the vertebral artery injury with the stab wound. So in this case, I can tell you either, we have Dr. Varon over at our institution, so I'm very comfortable having him intubate this patient and control him so that we can get adequate compression to stop bleeding. And then move them into the OR. But obviously, that could be done in the OR. The real issue is that if it is a vertebral artery injury, it's very difficult to get control in the OR, but you have no choice since this patient really is bleeding right now, and you need just topical compression. So I would also have a call in to my IR people to come to the OR. We have a hybrid room in case we have to continue with just pressure. So those are my comments. Dr. Kasim?
Good morning. Somebody has got the mic turned on. For courtesy's sake, could you please turn it off so we can hear all the words the other doctors are saying? Because I'm having difficulty following everything. So having said that, here is my answer to Dr. Ginsburg. The way that I look at this case, I utilize a mnemonic.
One second. We have a real problem with this mute.
Hugo Garcia, please mute. Hugo Garcia, por favor, mute.
The way I look at this case in a patient who is bleeding, I use the mnemonic, which is called hard brewy, HARD. H stands for hemodynamically unstable. A stands for arterial bleed. R stands for rapidly expanding hematoma.
We've got 1 second, 1 second, 1 second, Dr. Kassim. Liliana, we have no control here, and it's impossible to hear the people talking. Paula, is that Paula Ferrada?
The open mic is Hugo Garcia.
Hugo. Hugo. This is horrible. Now it's Marcos Lete Gomez. Marcos, please mute. Okay. No. Okay, go ahead. Go ahead.
So, like I said, the D stands for disability cardiovascular neurological. So, in a patient like this, I would not take him to the trauma bay. He really should go straight to the OR, where you should have all the amenities available, because the dictum in surgery is you got to stop the bleed. And you either do it with balloons and other tamponade agent, or surgery is the answer. So where this can be done is in the OR.
Aquí da gusto ir, ¿me entiendes?
So, but before you can do any surgical approach to this, the patient needs to have his airway secured. So again, this can be safely done in the OR because you have all the facilities available. Now, in order for you to secure the airway, you not only have to have an expert in securing the airway, you also have to have other equipments available just in case that you fail to secure the airway with the usual laryngoscope or video laryngoscopy or whatever it is, which means you must be able to get control of the airway either with a cricothyroidotomy or open tracheostomy, whichever one that you are comfortable with. But the wrong thing to do is a blind intubation, thinking that you are going to achieve this, and that is going to be catastrophic. So in my opinion, this patient does not go to the trauma bay. He goes straight to the OR, where people like Dr. Warren or somebody in your hospital who is an expert in intubating the patient, where he will get intubated, and surgical approach is the way. If he was stable, that's a different ball game altogether. He would have gone to the CT angiography. Thank you.
Okay, one more. Supa?
Good morning, Dr. Ginsberg. I agree with all the comments. I think if you have the OR nearby and the patient is still talking, you can just move him to the OR and secure his airway and explore the neck. But if the OR is far away and you need several minutes to take the patient there, intubating him in the ER is a safer approach. But you need to prepare for difficult intubation, like Dr. Veran mentioned, and maybe for surgical airway. Thank you, Dr. Ginsberg.
Okay, let's we'll try to get more people involved in comments. Let's keep going.
Okay, so wait a second. So at this point, just to recall, the patient was unstable. He did talk, but at this point, other than the pulsatile bleeding that we saw, despite the direct pressure, we also saw expanding hematoma. And at this point, we were not sure that the patient will make to the OR until without his airway to be secured. So we decided to do it in the trauma unit. And the first good point that you all mentioned is understand that we're facing a difficult intubation, meaning we're not going to intubate on blind. So we prepared all the team. We took the video laryngoscopy, and then we tried to do the intubation, which failed twice because there was edema, a bit edema of the trachea and the vocal cords. And that's when our ENT specialist tried to do the cricothyroidotomy, but it was failed due to some technical issues. And the last option to secure his airway because of the expanding hematoma and his hemodynamic state was to perform a tracheal cut and to just put an endotracheal tube over a bougie. So basically, that's how we managed to secure his airway. It is important to, although we're talking about the schema, but the parallel to that, we had this active bleeding which we had to control, and because we could not control it using direct pressures, so we used another method using the Foley catheter. Which we just put over the trajectory that we saw and inflated. We used 2 Foley catheters, and at this point, the bleeding became slower. We still had some oozing from around the Foley, so it was, I would say, better controlled. And of course, we started a massive transfusion protocol. Maybe we're all familiar with the Foley catheter balloon tamponade technique, which we know that is pretty effective, around 97-98% of success rate. With in many cases, we can use more than 1 or even 2 Foley catheters, and this technique might also be used in the various levels of care, also in the pre-hospital care. With a very low complications rate. So basically, it's something we all should always remember. Where our direct pressure is not successful, we always have to remember this option. So just to summarize, we have an unstable patient with zone 2 penetrating injury, surgical airway, with still ongoing bleeding. It is better controlled now with the Foley catheters, but it's hard to say that it stopped. And he already received about 6 units of blood, red-packed blood cells, and 2 units of fresh frozen plasma. Okay, so we all talked about the zone treatment, and we know that today we try to focus more on the no zone treatment, right? Based on more on the general condition of the patient, whether he's stable, unstable, or we have some hard signs. So this patient, because he was unstable, and we still the bleeding was ongoing, so we decided to take him to the OR. At this point, the airway was secured. It was not a definite airway, but it was secured. And we encountered some ventilation difficulties. So we x-rayed, because we did not x-ray the patient in the trauma unit. We x-rayed the patient, where we saw a pneumothorax from the right. So we added a chest drain to his right hemithorax. And regarding his hemodynamic state, so we saw that he starts to respond to the massive transfusion protocol, with his pulses going down, his pulse pressure becomes wider. He was not on vasopressor support. We see the x-ray after we inserted the chest drain. And also his blood, arterial blood gases, we see that his PCO2 goes down and his lactate goes down, and basically we see that the patient stabilizes. At this point, we had another, I would say, small discussion between us. What do we do now? From on the one hand, we're in the OR, but the setting has now changed. We're talking about a stable patient with still the zone 2 penetrating neck injury. His surgical airway is now secured, and there is no active bleeding. I didn't mention that we added some more sutures around the Foley catheter. So basically, we felt that at this point the bleeding is managed.
So I will describe the situation like this. I'm about to start the neck exploration. I'm already prepped, and with a knife, we already placed the chest tube, and the patient is more stable, as Dr. Gaft said. And this vascular surgeon behind me, the vascular surgeon behind me all the time whisper, let's go to the CT scan. Let's do CTA. Let's go to the CT scan. Don't do the exploration. Skip the exploration. He's getting better. He's more stable. Let's go to the CT scan. And we are in the operating room. The neck is already prepped. And I want to ask you, after we place this chest tube, we see the patient is more stable, if you will abort the operation and go to a CT scan, or you will continue with the operation.
Okay, so in Dr. Umtrecht?
Yes, so exactly. So in this case, because you suspect, it's in the posterior triangle, you suspect possibly a vertebral artery injury. And if the patient is really stable, and it seems like the instability was caused by the pneumothorax, I'm surprised that you heard equal breath sounds bilaterally. And that can be difficult in a noisy ER or in the ambulance. But I think if you look for the sliding on ultrasound, you would have seen right away that he has a pneumothorax, although why he wasn't stabbed on the right side where the pneumothorax came from. But then you would have put the chest tube in earlier, and that might have changed your clinical picture. But in this case, if he really is stable and the bleeding is really controlled, I wouldn't go to CT scan. I would go directly to interventional radiology, where you see where the bleed. You know he's got a vascular injury, so you see exactly where it is, and possibly the vascular surgeon or the radiologist can put a stent over it, or embolize it if it's the vertebral artery, that then you can't stent it. But I would, if anything, I would either proceed with the neck exploration, or if the patient's really that good, go to interventional radiology.
So proceeding with the neck exploration is an option.
Yes. Let's get some other opinions, Alon. Supa. Supa.
I agree with that. Neck exploration is the standard treatment for this patient. But since the patient is now more stable, and if you have IR available in your hospital, I think a CT scan of the neck would give more information, because sometimes IR can help us with the bleeding that is difficult to control surgically, like in zone 1 or zone 3. Thank you, Dr. Ginsberg.
Okay, how about Dr. Garcia, Hugo Garcia? Okay, how about Dr. Kasim?
I am rather surprised that the vascular surgeon who was whispering evil to my good friend Dr. Schwartz. That is terrible. I think Dr. Schwartz is a surgeon, and a vascular surgeon is telling him to send him to the CT scan. No, the answer is absolutely not. In a case like this, if you send the patient to the CT scan, and more than likely he probably will crash in the CT scanner, And I think you got the patient under control. And like they say, strike it when the iron is hot. I think this patient needs to be explored, which Dr. Schwartz was about to do, and I would continue with that. CT scan at this time is not going to be really all that helpful to you. You need to stop the bleed. It may not be the vertebral artery, it may be something else. If it is a vertebral artery, it will declare itself once you open the neck and you will know exactly where you are. And at that time, you may want to deploy some other modality to stop the bleed. But right now, I think Dr. Schwartz is in the right path, and I would continue with that. Thank you.
Okay, so in summary, we have several who feel that the patient is stable and would rather get more information in case it is a vertebral artery injury or something different, considering that you've got a pneumothorax on the right side. This stab wound penetrated, the thoracic outlet vessels, possibly subclavians, which could be managed non-operative, open operative with stents or embolization if it's the vertebral artery. And then we have other folks. Obviously, we have the opinion that we're there, we're under control, and we could always, start with a median sternotomy to get exposure of all these areas and get control of the vessels and fix them right away, taking a chance that if it's the vertebral artery in the bony section of the vertebra, that would be extremely difficult to get control without IR. So angiogram, as Dr. Utrecht, would be used in this type of case. So what did you do?
Yeah.
So as you all mentioned, this debate was done by all of us, and because we had the pneumothorax on the right side, and we felt that patient is stable enough, his airway is secured, and since we thought that the trajectory might surprise us, we decided to go to the CT angio. And then after the CT angio, we tried to figure out the trajectory. The trajectory. Okay, so I will summarize what we found.
See, like here.
Okay. Yeah. So you can see in the
pictures.
middle. Yeah, there is in the middle the image in the middle. You can see the trajectory of the knife. You can see the folly. And what we found is that there is a pseudoaneurysm of the right thyrocervical trunk. The pseudoaneurysm of the right subclavian. We found a pseudoaneurysm of the right subclavian, a pseudoaneurysm of the thyrocervical trunk with extravasation and active bleeding. We also noticed, as we mentioned, some pneumothorax and pneumomediastinum, and a retrotracheal hematoma that might maybe hint for some aerodigestive also injury. So as we said, most of these or all of his injuries were on the right side. And as we mentioned, we were about to explore his left side at this point, before moving to the CT angio.
So clearly, if we were going to exploration, we had to finish up with the median sternotomy, control of the large vessel, probably big mess that probably we could avoid. And we went from the CT scan to the angio suite. And this is what we saw.
Yeah, so there we basically treated all the vascular injuries. We see the pseudoaneurysm in the right subclavian. So we put a stent. It is important. We'll see at the end of the procedure, the stent we were able to avoid covering the vertebral artery. And then we saw the pseudoaneurysm and the extravasation from the thyrocervical trunk, actually from the right inferior thyroid artery branch. And this was closed using onyx. It was we used like embolizant. And that's how we managed to basically treat all the vascular injuries. We can see here an aortogram where we see basically it's an aortogram after the deflation of the balloon, of the Foley catheter balloon. So first of all, we saw no active bleeding after deflation of the balloon, and what we see is the vertebral arteries are open with flows, and the bleeding was well controlled. At this point, we're asking, what are we done here? Basically, our vascular injuries were treated by our amazing IR team. We understand that a more definite airway management is still needed. I recall that we have a tracheal cut with an endotracheal tube inside. So maybe we should move on for tracheostomy. And also, as I mentioned before, due to the findings in the CT, there is high suspicion of aerodigestive injury because of the hematoma that we saw, the pretracheal hematoma. Of course, and the trajectory. Of course, the patient did not have oral contrast, so we cannot say anything about the esophagus. So at this point, putting all this together, we go to the OR and we move on. We do the tracheostomy with additional neck exploration, see no other injuries, and we'll also perform some rigid esophagoscopy showing no injuries to the esophagus. What?
Tracheostomy.
Yeah, and we did the formal tracheostomy, of course. So basically, finally, it appears that we are done, and our next question would be, what is the patient? We take the patient to the ICU unit where he stays about a few days. He's weaned from ventilation. He's stable with no neurological deficits. At this point, after it seems that everything was treated, what would be, in your opinion, the best placement for this patient? For how long, and what further evaluation would you like to consider in this patient?
Basically, the question is for how long you will hold this patient in the intensive care unit, when you'll be, say, he's with tracheostomy now. Yeah, the tracheostomy is in place, but the question is for how long you will hold this patient in the intensive care unit, and if you will have a mandatory exams before you transfer this patient to the ward.
Okay, Dr. Umtrek?
Yes, so, he has no aerodigestive injury, a couple of vascular injuries that you took care of. He was fully awake before, so I assume he's fully awake now. And, I think you can move him out of the ICU, still with a tracheostomy, perhaps do a gastrografin swallow or a barium swallow or a CT scan of the neck and chest with contrast, and be totally sure that everything is fine, that the hematoma is resorbing, and then just move along. Take him out of the ICU. You may you need to keep the before you can decannulate him. I don't know if you wait a week or so, let a fistula form, and then decannulate him. But I can't think of any subtle other injuries that may present themselves. But I would move him out the second, third. At this point, I think it's reasonable to move him out.
Dr. Supa?
For his airway, I think if we have tracheostomy now, you can keep it for like several days, and before decannulate the tracheostomy, you should let the ENT people examine the vocal cord and the anatomy of the airway. Maybe follow up CT scan of the neck to check the rectal tracheal hematoma, whether or not it resolved with time would be a safe approach before decannulate his tracheostomy tube. And if we are not sure about the coverage of the right vertebral artery when you place a stent, postoperative CTA of the neck will give you more information about cerebrovascular anatomy for this patient. And if he's stable enough, I agree with Dr. Untrat to move him to the floor. Okay. Thank you.
Dr. Kasim?
I think I would call in my ENT colleague to have a look at the vocal cord and the trachea and leave him on the tracheostomy for a week to 2. And then after that, you can wean him down off the tracheostomy. And then when he's all better, you can send him for an angiogram to see if there's if the stent is in the right place and what you're going to do with the stent later on. And then he should be fully recovered, and he should be on the regular ward, and his aerodigestive structure is intact. He should be able to, nutritionally support himself and ready for discharge.
Dr. Varon, who is a master critical care specialist, what are your thoughts?
So I agree with Dr. Kasim. We still don't know why, sorry about the dogs. We still don't know why they couldn't intubate if he has a laryngeal injury. So before he leaves the ICU, I would take him back to the OR, have the ENT examine the airway thoroughly, make sure that, as Dr. Kasim mentioned, that there's no vocal cord, epiglottis, or other injuries that could have explained the difficulty in intubation before even thinking about the cannulation in this patient. You already mentioned that mandatory esophagoscopy was already done. It was negative. So that's probably the most reliable way to do that, maybe even more than the barium swallow. So once you have cleared the esophagus, and once you have realized that the airway is okay above the level of the tracheostomy, then all those tests can be done while in the ICU. Then he can go to the floor and eventually be decannulated.
Okay, just a comment about, so I think we've gotten a good opinion as to when and what. We must all remember that even though we're very comfortable with esophagoscopy, the combination of esophagoscopy with a contrast swallow is the most accurate, although a lot of times we just go with the esophagoscopy and the CT scan. So anyway, what'd you guys do?
So we clearly didn't do all these exams. We transferred the patient to the floor once he was completely neurological with no deficit and he was awake and he has tracheostomy. So we said, okay, it's fine to move this patient to the floor. And this is what happened.
So basically 5 days after admission, it was about 2 days after he went down from the ICU unit. The patient was found in dramatic distress in breathing. We called the ENT team and made urgent bronchoscopy, which found a large mucus plug that was extracted. And then a few days later, we performed another bronchoscopy with some more edema of the trachea, and the patient started on steroids. But then 7 days after admission, a week, it was everything. At this point, I would say we transfer after taking out this mucus plug. We took the AC. Okay, and about a week later, a week after admission, there was a recurrent active neck bleeding. So at this point, with this active neck bleeding that occurred,
like suddenly like the physician in house calling me, like surgeon in house calling me, come quickly, the patient starts bleeding again, arterial from the same stab wound, like the stab wound was already closed, and the patient start to bleed again from the same stab wound on the floor, and we are on the floor.
So we take the patient.
So we placed again. So we use the balloon with the Foley. We placed 2 Foley again balloons, and we went straight without CT scan, went straight to the angio suite, and this is what we found.
So we found another bleeding from the thyroid cervical trunk and the left vertebral artery. We found a pseudoaneurysm with extravasation. At this point, it was the left vertebral artery. Just to recall, all his injuries at his presentation were on the right. So what we did is our IR team treated this using coils with good control on the bleeding. That was the basically what happened. Basically, up to date, the patient went home, was discharged about a month after the incident. And on a follow-up in the trauma clinic, outpatient clinic, the patient is overall feeling well. He's daily active with some mild dyspnea and exertion. He does describe odynophagia, pain while he swallows, and he still suffers from left brachial plexus palsy. So basically, this is the case. I think this case, in our opinion, demonstrates the zone versus the no zone, let's say, approaches, and the need to understand that sometimes the trajectory might be other than what we expect. And in this case, this demon that our surgical, the vascular surgeon was telling us not to go to the CT angio, in this case, prevented from unnecessary exploration, of course. That's in our opinion, basically.
Looks like this stab wound went through all the zones, correct?
Exactly, exactly. So the stab wounds from posterior left arrived to zone 1 on the right, like to subclavian and thyrocervical trunk on the right, without penetrating the esophagus or the trachea. This is also another like not understanding exactly the trajectory, and causing pneumothorax on the right, which also wasn't expected and wasn't diagnosed in the trauma bay. So I think you know, the no zone theory is just
remember this patient had a cricothyroidotomy that failed. You could get a pneumothorax from that. So we just have to consider that could have been a cause for the pneumo.
I think it was from the knife itself, because the knife itself like caused a pseudoaneurysm of the subclavian on the right. The apex of the apex of the right lung is there. It's basically just there. And I think there wasn't pneumothorax on arrival. It just when we intubated and start to ventilate him on a positive pressure ventilation, so this what enlarged the pneumothorax. So pneumothorax probably was very small when he arrived, and this is why we had bilateral breath sound. But then after a positive pressure ventilation, he developed like this big pneumothorax and became unstable, although we transfused the patient like with blood, so we didn't understand exactly the clinical picture. But this is like I think in this, like what's nice in this case is the trajectory. Like the no zone theory is just demonstrated perfectly, because from left neck stab wound, you can get right side injuries, which is completely managed better with angio. And if you can stabilize the patient with no exploration, you can avoid a very extensive exploration. Because if we would explore, like if I wouldn't listen to this vascular surgeon whispering in my ear, CTA, CTA, I would probably end up with median sternotomy, and I'm not sure that I will be able to save the patient. You know, this is probably, there is a chance that I would have lost the patient. So this is also a consideration.
Fantastic case, Alon. Good suspicions. Any other comments from anyone in the audience?
What would have happened if you don't have an IR as efficient as Dr. Schwartz hospital has? Then what would you have done?
Alon?
Yeah, probably neck exploration. There is no, but I already asked for the cardiothoracic surgeon to be also like to come. He's not like home, he's home call. So yeah, I asked him to come from call because I expected that I will end up with sternotomy. So clearly, if you have no IR ability, so you have to do first median sternotomy before you go into the neck, control the great vessels, and then go to the neck.
I've never done this but I've seen it once that I can remember somewhere in the recesses of my mind. For a vertebral artery injury that is within the canal, not within the canal, but within the vertebra, you literally would need to find a way to either ligate it inferiorly, off of the proximally, but then you can get bleeding retro. And I've heard described the use of a rongeur to get the bone off to try to get control of that vessel. But obviously this was managed very, it's just great that the way this was managed. And it just goes to show you, thank God for technology. Dr. Utrecht?
Yes. So what a fantastic case. But a comment and two questions. The comment is, I think you need to get one of your interns to work with a radiologist or the tech to do a 3D reconstruction. I can't imagine how the knife went, what the trajectory must have been just to nick a couple of vessels without slashing through anything else. I mean, I just can't imagine how that happened. And it'd be very interesting to understand that better. Now, about the why go to CTA if you have interventional radiology? It would have saved you, 20 minutes or so. Why not just go directly? If you know the patient's bleeding from somewhere, then the interventional radiologist can diagnose it and fix it at one step. And then the other question is, you said you did an exploration at the time with a tracheostomy. Why not just do the tracheostomy? Because you already had enough information to know that it was unlikely that there was anything, that you looked at the esophagus, the trachea is already intubated, and why explore? And the exploration didn't, you weren't able to see the pseudoaneurysm in the left vertebral anyway until it occurred. So, that's the other question I had.
Okay, so I'll answer the first question. The CTA, the vascular surgeon who actually performed the intervention with the IR team, he asked for it, and basically the approach for the subclavian was from the radial artery of the right hand after they had the information from the CTA. So like the CTA changed all the view of this patient. Like suddenly you're dealing with right side, and then you can approach it, and the subclavian bleeding are better approached from the radial artery and not from the groin. From the groin, the angle is very hard to get. So this is the answer for the first question. For the second question, this is like the comment that you had, that the knife went from the left neck to the right neck, to the right, like chest, actually, yes, without penetrating, was very awkward for us. And we wanted to see in our eyes that there is no esophageal injury or tracheal injury or anything else. So we did this exploration and basically placed JPs and just, as a surgical technique, the normal surgical technique. But it's really awkward how it didn't penetrate any other structure, but this was the reality, this was this is the reason that we performed the neck exploration.
Did you say right brachial artery or brachial?
The what?
Left brachial.
The right brachial. Okay, I heard radial. So I would
radial. The approach is radial. The approach is radial.
You can do that. You can put a
yes. You do. At first, they put like something to expand the diameter of the radial artery, and then you do it through the radial and put this stent in the subclavian from the radial approach. Yes, radial. He
Very
did
nice.
develop a embolus or thrombus, and he did the embolectomy of the brachial after this procedure. But this was we didn't describe it here, but because it was like minor complication, but he did the thrombus of the brachial artery, and then he did embolectomy. But radial artery, yes, radial artery.
And second time through the groin. Second time through the groin for the vertebral.
For the vertebral through the groin, yes.
Fantastic.
Very fantastic case.
Yeah.
And as they say in Israel, Yofi. So congratulations. Any other comments from people in the audience?
There is an alternative way of treating the vertebral artery injury as well. I've seen a couple of cases where they have put a glue. They control the bleeding, take the Foley catheter out, and then follow the track and insert fibrin glue or some other glue. And it seemed to have worked.
Like in the bone, like where, like in the between the vertebra.
Right, into the area.
Okay, very good. Thank you all, and have a nice Labor Day. It's a holiday in the U.S. today.
Yeah.
Boker Tov.
Okay. Boker Tov. Happy Labor Day. Go shopping.
Guys.
What you're doing here.
Bye-bye.
Bye-bye.
Say bye.
Bye.